bone marrow transplantation has been a very successful immune therapy for a lot of the blood cancers, leukemias and lymphomas, as well as I'm pediatric, and in pediatrics, about half our transplants for children that have various marrow or immune disorders as well. And when you look at the outcomes of transplant, although highly successful as an immune therapy for malignancy, either the malignancy comes back so it doesn't work, or the other one is development of particularly the graft-versus-host disease as a chronic form. There's an early form, acute, and the chronic form, though, in children, it's about 15 to 20%, and in adults, it happens in 30 to 40%. And it leads sometimes to a lifelong disease and highly debilitating, with decreased quality of life and an increased mortality associated with it as well. So you can be basically cured of your leukemia and yet have some of the long-term complications from transplant, particularly chronic GVHD. So there's been a lot of strategies to prevent chronic GVHDs as preventative therapies. Things like using antithymocyte globulin, the post-transplant cyclophosphamide, alemtuzumab as examples. And those have worked to an extent in bringing the rate down, but we still have problems where there's still a group of patients that develop it, and it can be, as I've said, lifelong. So the second type of strategy is to use a preemptive approach. Preemptive approach means that you have already had your transplant, and then you're trying to minimize the development of the GVHD after transplant by a second measurement at some point in time. So the way to do that is, it appears at this point in time, is to use a combination of tests, what we call algorithms, either for acute GVHD or for chronic GVHD, putting those tests together to see if you can predict it, what's called a risk assignment biomarker or biomarker algorithm. So acute GVHD, that means measuring very early, something like 7 days after the transplant. And there has been one trial using a validated biomarker algorithm. Unfortunately, it was not successful. So I think work needs to happen still on what's the best intervention. The area I work on more primarily is in the chronic GVHD. And so what we're looking at is a test that might be performed between 60 and 100 days after transplant before the development of chronic GVHD. The chronic graft-versus-host disease usually starts up as early as 80 days after transplant. So what we are in the process, and we actually have developed a risk assignment algorithm in children, and we hope to apply this in adults as well. And we're in the process of validating that at this point in time. Once that's been validated, we hope to then take therapies that might be used that have been successfully used to treat chronic GVHD, and use them early in the high-risk patients to prevent it. And the other thing about these algorithms is, if you know somebody has a low risk for development of either acute or chronic GVHD, you may be able to decrease some of the medications we use or take them off earlier, minimizing the toxicities of the side effects of the medications. So that's in a nutshell what we're going to be talking about. I think we're at early points in this. Really, what we want to do is eliminate GVHD as a complication of transplant, if at all possible. And I think these are the approaches to try to do it, so that we have the highest cure rate with the minimal toxicities or side effects of the GVHD.